Dear colleagues, welcome to our monthly dialogue. I remind you that our dialogues are live streamed in X and then posted in X and YouTube. Today, as usual, will be a lovely conversation, will be a lovely dialogue on a very interesting topic, factor 11 inhibition for anticoagulation. It is a fascinating topic. We still between Scylla and Charybdis. When we use anticoagulants, we want to avoid the ischemic events, but also we want to avoid the excess of bleeding risk. Is factor 11 inhibitors the magic bullet which allows to navigate safely between Scylla and Charybdis? This will be discussed today. This dialogue has been organized by our mini team responsible for weekly journal scan, led by Carlo Patrono, who is with us. And today he will host this interesting dialogue. And please, Carlo, can you introduce it?
Yes, thank you, Filippo, and welcome to all the participants. So the theme of this dialogue is where is the field of oral anticoagulation going after Asundexian failed in atrial fibrillation? And the guests joining the panel are Jonathan Piccini, Bianca Rocca, and Hugo Cate. And this distinguished panel of experts will address the following main questions. Why phase 3 trials may fail? Is it failure of factor 11 inhibition, or is it Asundexian failure? Thirdly, what is the adequacy of Asundexian phase 2 studies? And finally, where is the oral anticoagulation field going? So Jonathan Piccini is a clinical cardiac electrophysiologist and professor of medicine and population health at Duke University Hospital and the Duke Clinical Research Institute. His research interests include the development and evaluation of innovative cardiovascular interventions for the treatment of heart rhythm disorders. He is an associate editor of JACC for clinical electrophysiology and an elected member of the American Society for Clinical Investigation. He has more than 600 publications in the field of heart rhythm medicine. Bianca Rocca is professor of pharmacology at the LUM University in Bari, Italy. She has served as chairperson of the ESC Working Group on Thrombosis and is currently chair-elect of the ESC Working Group on Cardiovascular Pharmacotherapy. Her main scientific interests are related to antithrombotic drugs, eicosanoids, hemostasis, platelets, and precision cardiovascular pharmacology, topics on which she has co-authored over 200 publications. And finally, Hugo Cate is professor of clinical thrombosis and hemostasis at the Cardiovascular Research Institute, Maastricht, which is one of the 8 research institutes of the Faculty of Health, Medicine, and Life Sciences of Maastricht University in the Netherlands. In addition, Professor Cate is adjunct professor at the Center for Thrombosis and Hemostasis at the Gothenburg University Medical Center in Mainz, Germany. A specific focus of current research is the pleiotropic actions of coagulation proteases in atherosclerosis, atherothrombosis, and ischemia reperfusion injury. He is currently involved in several multidisciplinary research programs, including RACE5, which deals with coagulation and its impact on atrial fibrillation, and CONTRAST, which deals with acute ischemic stroke. And he has more than 300 publications on these topics. So, Jonathan, the floor is yours. Would you kindly give a brief presentation of the Duke Clinical Research Institute and your main research interests, and then describe the rationale design of Oceanic AF and its main results?
Sure. Well, it's a delight to be here with all of you, and I'm very much looking forward to our conversation. I am an investigator at the Clinical Research Institute here at Duke in Durham, North Carolina. the DCRI, and I think what we are probably what we think is the most important to know about our organization is that we are a very eager and proud participant in international collaboration for the conduct of clinical research, including large international randomized controlled trials, of which Oceanic AFib is certainly one. And it's very humbling with so many experts on this discussion today to highlight the rationale for Oceanic AFib. So I'm going to share some of my own personal perspective as an investigator. I was very excited to begin studying these compounds and familiarizing myself with the story of factor 11. And as many of on this call I know are aware, patients with factor 11 deficiency will have bleeding after surgery or other provocative challenges, but they very rarely have spontaneous bleeding. And it's believed that the factor 11, while intimately involved in the contact pathway mediated formation of thrombus, largely is uninvolved in tissue factor mediated thrombus formation. And so inhibiting factor 11 may help prevent pathologic thrombus formation without impairing normal homeostatic responses to bleeding. And what's even more fascinating to me is when you look at the population genetic studies, it appears that patients with factor 11 deficiency have a much lower incidence of vascular events, including deep venous thrombosis and stroke. Asundexian is a small molecule factor 11A inhibitor. And in the Pacific AF phase 2 study that was done during the COVID pandemic, when we compared 2 doses of Asundexian with standard dosing of apixaban according to the label, we saw a dramatic reduction in clinical bleeding with Asundexian. That formed the rationale and impetus to conduct a pivotal international phase 3 trial called Oceanic AFib, where Asundexian 50 milligrams once a day was tested in a randomized trial against apixaban standard dosing in an intended 18,000 patients with atrial fibrillation and risk factors for stroke. We randomized over 14,000 patients. The primary endpoint of the study was first to demonstrate the non-inferiority of 50 milligrams once daily Asundexian for the prevention of ischemic stroke and systemic embolism. And the additional endpoint was to demonstrate that Asundexian was superior for the reduction in major bleeding. The trial did not reach conclusion, as after 14,810 patients were randomized, the study was terminated upon the recommendation of the Data Safety and Monitoring Board because there was an excess of ischemic stroke events in the persons randomized to Asundexian with a hazard ratio greater than 3. During the brief follow-up, which was on average 6 months or so in patients with a mean age of 74 and a mean CHAS-VAS score of 4.3, approximately 18% who were OAC naive, and an additional 18% who had a prior history of stroke or TIA, we did see lower rates of bleeding. The clinical relevance of that, given the overall finding of Oceanic AFib, is unclear. And with that, I will keep it brief so we can get straight away to discussion. Obviously, there are lots of hypotheses for why Asundexian 50 milligrams once daily may have led to an increased risk of ischemic stroke relative to apixaban.
So before I turn the floor to our discussants, what is your favorite explanation for the failure?
Yes, well, so I would say as someone who's dedicated their career to studying atrial fibrillation and heart rhythm disorders, it may not be one particular mechanism that led to the result we observed. We know from factor 11A assays that we did in Pacific AF that we think at peak dosing, Asundexian 50 milligrams leads to a 94% reduction in factor 11A activity. So one hypothesis is that that may not be enough. We may require near complete suppression or complete suppression of factor 11A activity to have meaningful reduction of ischemic stroke. The other possibilities is that the effect is specific to Asundexian, perhaps a molecule that could inhibit both factor 11 and factor 11A may be more effective. And then it's also possible, as we know, patients who are on a therapy for a long period of time and do well on that therapy are a selected group. And so it's possible that that may have also played into the result that the vast overwhelming majority of the population, 80%, were patients experienced to oral anticoagulation and direct-acting oral anticoagulants, and that may also partially explain the result we saw. So, Dr. Patrono, that's not my favorite hypothesis. That's my favorite 2 or 3 or 4.
Okay. So, Bianca, would you like to comment?
So about my favorite hypothesis, my favorite hypothesis is that possibly there was too much enthusiasm in trying to, put a division between hemostasis and thrombosis. So the hypothesis might have been a bit too optimistic, especially in a context as atrial fibrillation, where the way clots are formed in terms of place, shear stress, involvement of the endothelium is much more complex than possibly VTE. In my opinion, there are still many aspects that are known from the human deficiency of factor 11, and therefore maybe this, going from a disorder to a pharmacological intervention when still there are some, missing or unclear aspects of the human disorder, might have been a bit of a stretch. So that's my favorite hypothesis. Then, why phase 3 trial failed? There are many different reasons for that, more general or more specific. Another aspect that I would like to bring on the floor is the way biomarkers are used to define pharmacodynamics in phase 1 and phase 2. Sometimes, as happened in the past, there was an over interpretation of some in vitro assays that hardly reflect the complexity of a disease. As for instance, for Vorapaxar, which failed based on bleeding time and platelet aggregation assay. So I think there are many possibilities related to the hypothesis and to the role of factor 11. But then I will leave the comment to Hugo.
Thank you, Bianca. I agree with with everything you said, I think, but certainly also with the lack of knowledge that we might have on the pathogenesis of thromboembolism in atrial fibrillation. There's a lot of older literature also describing several key players, including platelets, although we know, of course, that anticoagulants are superior to antiplatelet agents in preventing thromboembolism. But still, it means that there are different players involved, probably not totally comparable to the situation in venous thromboembolism. And also the phase 2 studies that were done to demonstrate efficacy for venous thrombosis prevention are confined to a human model of knee replacement surgery. So that's also a very specific situation. And I think it remains very hard to extrapolate that towards a situation of atrial fibrillation. There are many unknowns. Perhaps one of the questions that Bianca and I and a few others also discussed, was the matter of the dose. Was it too low or not? And maybe I could ask Dr. Piccini to comment on this, because I'm sure that the steering committee, also in communication with the company, discussed the issue of, is this sufficient 50 milligrams? Of course, 20 and 50 milligrams were tested in the phase 2 study. And I was wondering, is there any reluctance? Was there any reluctance in going to higher doses? Was there still a fear of bleeding complications, for instance, although the concept is, of course, that it may be safe with regard to spontaneous bleeding? Or were there concerns perhaps about increasing the already quite high concentration in molar terms, which would make put the way open to perhaps other less specific effects than just the inhibition of 11A, for instance, the inhibition of other coagulation proteases. So perhaps, Jonathan, can you comment on the issue of dose, because that's quite intriguing, and it's also one of the main points that's mentioned in the New England article.
Yeah, so I think, as everyone appreciates, dose selection in phase 2 studies and then subsequent for phase 3 studies is incredibly challenging. There is a pragmatic limit to how many doses can be tested, meaning that, if you design a phase 2 study with 10 doses, that's going to be an incredibly large phase 2 study. The rationale for the doses tested was that, based upon the preclinical data and the suppression of factor 11A activity, that those doses, would be adequate. I do think that there, was a concern that, would complete suppression potentially have negative safety implications. When we thought about the design of the phase 3 study, and we were comparing 20 versus 50, we saw bleeding reduction with both doses. So, of course, we wanted on the side of efficacy, and there was no evidence. Granted, it wasn't powered for cardiovascular events, but there was no real evidence of increased cardiovascular events in the Asundexian group. We've been asked, why was there no DVT prevention study? I think it's already been highlighted in the conversation that mechanisms of thrombus formation likely differ between deep venous thrombosis, between atrial fibrillation, and even other cardiovascular pathologic processes. And sometimes DVT studies have been helpful with dose selection and determining efficacy, and sometimes they have not with respect to atrial fibrillation. So, moving into the phase 3 study, we thought we had a very compelling dose with a very compelling inhibition of factor 11A activity. Of course, that is just likely, one piece of information that may be helpful, but that was the rationale in the development of these clinical trials and the selection of the dose.
To address the dose issue, Jonathan, have you completed the PK/PD sub-study that was planned within Oceanic AF? I mean, is there evidence that higher drug concentration drives greater pharmacodynamics and possibly efficacy?
Yes, I want to be careful and don't want to speak to results that are final and that haven't been presented yet. We have briefly looked at the data and done informal analyses. We don't see any gross evidence that there was lack of effect with the 50 milligram dose, but we look forward to publishing not only the PK/PD data, but also data from our Nautilus biomarker sub-study that we think may also be very insightful into helping us discern why we observed the events we did.
Okay, and to go back to Bianca's comment on the underlying pathophysiological, what kind of evidence do we have in the search for the holy grail of disconnecting bleeding from thrombosis, that our body actually uses different cellular and soluble actors for the two plays?
Yeah, I would be in Camp Rocca that I think it is very difficult to dissect the two, and maybe they cannot be dissected completely. And I think for me as an electrophysiologist, two phenomenon that we've observed that I think reinforce that concept is that we know that when patients are in atrial fibrillation, as has been alluded to early, there is very potent platelet activation that's measurable and significant. And when patients are cardioverted and return to sinus rhythm, that platelet activation wanes but doesn't completely go away in persons with atrial fibrillation. The other thing, again, as a practicing electrophysiologist, when we put in left atrial appendage closure devices and we get patients off oral anticoagulation and even sometimes off antiplatelet therapy or down to minimal aspirin therapy, we still see very high bleeding rates. And so, again, I think untangling these two processes is not as simple as we might think. But lastly, I'll just say I also don't think we've totally answered the factor 11A question. We have some ongoing clinical trials with other compounds, including milvexian, another small molecule inhibitor, and abelacimab, a monoclonal antibody that targets both factor 11 and factor 11A. So I don't know that the answer is completely out.
Sure, and we'll come back to these ongoing studies and other compounds. But let me go back. I don't want to press you to disclose unpublished results, but can you tell us what sort of inter-individual variability in the PK-PD relations did you see? I mean, roughly what percentage of patients were above the 90% degree of factor 11 inhibition? Because that's a crucial aspect concerning dosing. I mean, one sees published results of the average population, but what is important is what is the inter-individual variability, which may be narrow or very wide, depending upon the individual drug.
Yes, the analyses that have all been done have really focused on the aggregate population, so I can't speak to inter-individual variation.
And in terms of the plausibility of the dose being inadequate to fully inhibit factor 11A, we have an example where the relationship between target inhibition and functional effects is strikingly nonlinear, and where you really need greater than 97, 98, virtually 100% inhibition, and that's aspirin in terms of COX-1 inhibition and thromboxane synthesis inhibition. The difference between aspirin and the reversible inhibitors of the same enzyme, the traditional non-steroidal anti-inflammatory drugs, which contributes to their markedly different cardiovascular effects, is that aspirin is unique among the whole class of these drugs through irreversible inactivation of the enzyme to achieve this high-grade inhibition of the target, which is not achieved with reversible inhibitors. So when we say, oh, there is a 92, 94% inhibition, in the case of aspirin and COX-1 inhibition is not sufficient.
Yes, of course, these are great examples where we have a lot of information over a period of time. At this point in time, we don't see any smoking gun evidence that the dose was inadequate, although clearly that's a very important hypothesis we have. We don't have any data or results that suggest that the 94% inhibition was an aberrant observation or an inaccurate observation, but the extent to which the in vitro measured activity reflects the functional effect, we are still investigating that with ongoing analyses.
Bianca, you are an expert in inter-individual variability. Would you like to continue? firing at Jonathan?
No, but I mean, I looked for inter-individual variability in the phase one published study at steady state, and in that published data, the variability was between 11 and 33% in terms of coefficient of variation. The other thing that
it's pretty high.
Yeah, exactly. At least the 33%. That was the range, but that was in healthy volunteers. And the other thing that I found interesting is that between the study in healthy volunteer, the degree of suppression was not completely superimposable to the data, the pharmacokinetic data on the phase 2 trial. So I'm wondering whether there is a higher level to start with in AFib patients that need, and in order to achieve the same level of suppression, you need somehow more drug, because in the phase 1 study, a large majority of the patients on 50 and 100 were just unmeasurable in terms of factor Xa activity, while that was not the case for the 50 at least in the data shown in phase 2. And again, I think that another thing that I think we rely too much on is the bleeding time in preclinical models. I mean, the bleeding time in preclinical models doesn't tell that much in terms of bleeding in humans. And even in humans, the bleeding time sometimes most of the time, the bleeding time does not predict the bleeding. So maybe relying a little bit less on bleeding time would be of relevance, and trying to understand different way of predicting bleeding, which is not the case of bleeding time.
John, any comment?
No, I think again, I'm a clinical trialist, so I think we're highlighting many challenges interpreting the information that we get from early phase human investigation and from preclinical science. And I think, to me, as a clinical trialist, it hammers home two messages. The first message is there's no such thing as an outstanding phase 2 study. Because phase 2 studies, by their nature, you're never going to have the sample size to answer all the questions that you want to answer, and you're never going to have the resources to make it large enough as you would like. And this is why pivotal phase 3 outcome studies are so absolutely incredible. Because as an investigator for the Pacific AF study, if you said, well, John, it's a limited sample, it's only several hundred patients, but do you see any evidence that you would think there would be a threefold increase in the incidence of stroke in the Asundexian arm? Certainly, we saw no evidence of that whatsoever when we looked at cardiovascular events in the small phase 2 study. So, as a clinical trialist, those are the take-home messages for me.
John, there is a problem with phase 2 studies, which have shown a tendency to become somewhat larger than they used to be in the past, because primarily industry wants to see some evidence of safety and or efficacy, which phase 2 studies cannot provide. And I believe it's the wrong question to ask whether one experimental drug is safer than the reference drug, because you don't have the slightest statistical power to assess efficacy. And therefore, you cannot, if you see a difference in safety, you cannot distinguish between improved safety of the experimental drug or simply lack of efficacy. And the phase 3 trial in this case suggests that it's lack of efficacy, which gave you greater safety in phase 2.
I agree what you're saying, although I think it's a good thing that phase 2 studies are becoming larger. And I think we have a lot of work to do to make the experimental process more efficient and more beneficial to the public health. And I think adaptive designs is a great way to do that. We spin up a trial design for phase 2. We get an answer that we know is tentative and not firm, that we tear that entire trial structure down. We analyze the data, we make decisions, and then we spin up an entirely new trial infrastructure for a phase 3 clinical program. I think there's a lot of opportunities for efficiency, to improve dose selection, and to get us a higher yield and pivotal phase 2 studies. So I'm a fan of adaptive designs that can help with dose selection and help make the process more efficient.
Okay. Hugo, do you have additional comments or questions?
Yeah, well, yeah, I agree with the idea of the adaptive design. That's probably helpful in situations like this. No, I was considering biochemistry again. Well, we've discussed the dose and the expected variation in pharmacokinetics and dynamics. I guess you can also anticipate that there will be a lot of variation in the degree of factor 11 activation in humans, based on what we know from the genetics and the variations in factor 11 levels in relation to the risk of thrombosis and stroke. So there are many uncertainties to deal with. And I guess also the difficulty in interventions like this that go just outside the core of the coagulation cascade is that we really don't know how important this factor 11 loop is in the risk of thromboembolism in these patients. And the past has been pretty straightforward and simple, because if you block TANA or thrombin, you know that you will block coagulation anyway. And if the drug is sufficiently potent, it will always block fibrin formation. But here you're blocking a side track, 11A, and we have no idea whether it will work or not. And the assay that was used to test the degree of inhibition in plasma was a contact-activated plasma. So if you assume that factor 12A is the most important driver of 11 activation, that's a relevant answer that you get by seeing more than 90% inhibition. But if you assume, as many of us do, that tissue factor is the key driver of thrombosis to begin with, then the question is what's the predictive value of contact-activated, inhibited intrinsic system activation? So I think we need just more information. And I know in the ESC presentation, the discussion afterwards by Dr. Heilex, he also discussed the findings from thrombin generation experiments showing that if you block contact-activated thrombin generation, you can nicely do that in a dose-dependent manner with Asundexian, like with milvexian. But if you use tissue factor as a driver or as an agonist of plasma activation, it very much depends on the concentration of tissue factor, whether factor 11 is involved or not. So a strong trigger, high concentration of tissue factor is directly activating factor 10 and is not influenced by factor 11A at all. So yeah, we can speculate, of course, of how important tissue factor is in the setting of atrial fibrillation. But these conditions, these local concentrations and local situations may be determinants of whether factor 11A inhibition will work or not. So I'm very much looking forward to the Librexia study also, because that will tell us how important 11A inhibition is. Because I still think it might be, but you may wonder whether it is. And with milvexian, we have perhaps the additional problem of looking at some perhaps non-specific effects, because you go to even higher molar concentrations. So yeah, a lot of biochemistry. I'm sorry for that, but I think it's very intriguing. And we need studies like this also with negative answers to get an idea, to make us thinking again about what is happening. And it's a pity we don't have more, simpler and more straightforward animal models or in vitro models even to address this issue of thrombogenesis, because that could inform us perhaps better if we proceed with the next phase of clinical trial testing.
Hugo, I really appreciate your commentary. One thing that I've struggled with as I look at the results of Oceanic and consider these hypotheses, if the factor 11 pathway is really peripheral to what is at the crux of thrombus formation in these conditions, if that's the case, and I agree that may very well be the case, then when we go back and consider the population genetic studies, how do we explain the very significant reduced incidence of things like stroke and DVT in these same individuals? That's where I find the evidence is very conflicting and confusing.
I know, and I agree, although the evidence, of course, from the subjects with congenital factor 11 deficiency is limited because it's such a rare condition. And there is an interesting additional point that we should mention, perhaps, and that you also brought up, but because you suggested that perhaps in addition to inhibiting factor 11A, we should also inhibit factor 11 itself. And basically, that was the idea of the first proof of principle study, lowering factor 11 levels with RNA silencing. That worked quite well. But what may happen, and what we also know from data from independent groups in vitro work, that if you really lower factor 11 level, and that was also shown in mice that are completely deficient in factor 11, then there is another escape mechanism that may become operational, and that's kallikrein-mediated activation of factor 9. So then there is a bypass mechanism opportunity to circumvent factor 11 and directly activates factor 9. And it's interesting, if you look at the genetic data, there is this huge study in Nature that was published a couple of years ago, showing that it's not only factor 11, but also kallikrein that are key molecules in ischemic stroke, and in particular in cardioembolic stroke, I think. So there may be a situation also, if you interfere with the factor 11 mechanism, that you do not only inhibit factor 11A, but perhaps it also has some secondary impact on the way that kallikrein takes over in driving downstream intrinsic activation. I'm sorry again for the listeners, because it may be confusing biochemistry, but it's quite intriguing that there is a loop around factor 11 that may take over under certain conditions to activate factor 11, and of course factor 9, and of course then the net result may be that you only have limited power potency with your factor 11 inhibitor. So again, a lot to learn, and I hope that in the plasmas from these patients will be able, or somebody will be able to look with biomarkers to what degree, to what extent factor 9, factor 10, etc. is activated as compared to apixaban.
There are a few questions from our participants. One says, thank you. How close was the Asundexian stroke rate in Oceanic to what you would expect for placebo?
Yeah, it's a difficult question to answer. Let me just first assure everyone that Janos Olgren, Valerio Queso, and Manesh Patel are all very committed, as well as Bayer, to completing the biomarker analyses and getting all the data in the public domain so the scientific and clinical community can benefit. We can't completely, know what the placebo rate would have been, obviously. It is interesting that the rate of ischemic stroke in the apixaban arm was much lower than we would have predicted from data extrapolated from Aristotle or recent epidemiologic studies. So obviously, for many of us, myself included, Rocket, Aristotle, Rely, these trials seem like yesterday, but the reality is that they were a long time ago now, and we've had a lot of improvements in cardiovascular care that continue to drive the stroke rate down. So we don't know what the placebo rate would have been, but it with a hazard ratio of more than 3, for me personally, I'm not sure how relevant that information is.
But it's pretty close to the difference that you would expect from between apixaban and placebo, because the indirect estimate of apixaban efficacy is a 75% reduction versus placebo, which would correspond for the reverse to a 4-fold increase.
Maybe, yeah, maybe.
Okay, there is a more complex question from John Cleland. John, you may want to pose the question. So, Amelia, if we can unmute John Cleland.
Yeah, so very interesting, and we can see from this study that the rate of stroke and systemic embolism is less than 1% per year. So the issue then remains about the major bleeds, which were around about 2% per year. But I noticed that you were allowed to use aspirin and even dual antiplatelet therapy in the Oceanic study. And I just wondered whether that was the problem, and if we could just have, as some people may know, I'm not impressed by aspirin at all for just about anything. A few days after an acute vascular event, maybe, but should stop at 28 days. And we should just be getting rid of aspirin out of cardiovascular practice. So is aspirin really the problem here? And not that we need a new drug, but we just need stricter policing of aspirin use in atrial fibrillation.
Yeah, so let me just briefly speak to that. Certainly, I would agree that antiplatelets are widely overused in AF populations. In the Orbit AFib registry, for example, a full 60% of people with no documented coronary or vascular disease are on concomitant antiplatelet agents. So it's a huge problem. When we designed Oceanic AFib, we also wanted to enrich with patients who are higher risk for bleeding and stroke. That was an intent, a very specific intent of ours. And so we didn't want to completely exclude antiplatelet therapy, especially for those patients who had conditions that would require it. We saw no evidence of heterogeneity in those the results in those treated with antiplatelet agents versus those without.
So, but in the absolute risk of major bleeding in the apixaban group, which is really the one thing that's sort of might make you interested in this drug, what were the rates in the patients who weren't taking aspirin?
Yeah, I don't know that I have the rates of major bleeding by aspirin status in the apixaban treated patients readily available off the top of my head.
No, not surprised. A lot of data, but it would be a great thing to know, because if we got less than 1% per year major bleeding and less than 1% per year systemic embolism, do people really want to develop any more drugs in this area?
Well, the number of major bleeds was pretty low, if I remember correctly, Jonathan.
Yes, it was about 2% per year in the apixaban group.
Yeah, so it was 0.2% overall in those who received Asundexian, and 0.7% in those who received apixaban. Now, granted, follow-up was greatly abbreviated because the study was terminated prematurely. As to whether it's worthwhile to develop additional drugs, I certainly think it is. I mean, if you think about your classic CHADS-VASc 5, 6, 7 patient, reducing their stroke risk by 2/3 is great. That we should be doing that, but we're not getting it, to near zero levels. And we target residual risk in many cardiovascular conditions. I think we should be targeting it in atrial fibrillation as well, and that's why I personally am very excited to see results of studies like LAS4, which are going to combine appendage closure with oral anticoagulation. I suspect that's where we'll see the most optimal stroke reduction benefits.
Filippo. There is a question from Filippo Crea.
Yes, well, I would like to involve in the conversation Jur Tenberg, who is an associate editor of the Journal for Thrombosis and Antithrombotic Treatment. Jur, are you there?
Yes,
Okay. Well, I'm sure you find this topic very interesting with your experience. Any comments on this trial or a question for Jonathan?
I apologize, but I just logged in just 2 seconds ago, so I missed the presentation, unfortunately.
Perhaps even better, because I can tell you the topic is factor 11 inhibition. So we are discussing the recent trial and in general, what is the future of factor 11 inhibition. As you are naive, because you are just joining us, what is your gut feeling about the future of factor 11 inhibitors?
Well, to be honest, I'm at say the coronary field. I'm a bit disappointed by the results of factor 11. That's one thing to say. The other thing is that it's always on top of other antithrombotic therapy, which to me is not very logical. I mean, it should be instead of one of the two usually used drugs, whether it's aspirin or P2Y12 inhibitor. I mean, adding any additional antithrombotic agent on top of that will lead to more bleeds. And I don't think that's worth the possible reduction of ischemic events. So first, a bit disappointed about the results. And second, is this the best setup to test this new drug?
John, what was the percentage of your patients actually using aspirin or DAPT?
I was just searching for the exact number. It was a minority. Give me a second here. Let me open another file.
In the meantime, Hugo, any comment on this question?
I wanted to comment to yours.
Only 10%. Sorry.
How
Only
much?
10% of patients.
Sorry, how much?
10%.
10%. So that's not the problem that John Cleland was perhaps overemphasizing.
I was just responding to yours comment and his disappointment. I agree to some extent. I think as we discussed, the epidemiology and the genetics and preclinical studies, but mostly epidemiology and genetics, point to a risk association for variations in factor 11 level with venous thrombosis and with ischemic stroke. The question is which type of stroke, atherothrombotic stroke, probably less so than cardioembolic stroke. And also in coronary disease, atherothrombotic disease, there is no good evidence. The data are very inconsistent about the relationship with 11A and outcomes and recurrent MACE and so on. So I agree that probably in atherothrombotic conditions in the heart and in the brain, where we do have, at least in the heart, some evidence of the benefits of, for instance, the combination, the COMPASS regime, low dose rivaroxaban and aspirin, that has some added value, but also added impact on hemostasis, as you say. But there is probably no good rationale at this stage to expect that factor 11A inhibitors on top of platelet therapy will have a similar gain in efficacy without an impairment of hemostasis. So I think personally, if I would design studies at this stage, I would focus on venous thrombosis and hope for a better outcome in atrial fibrillation as main entities of focus.
Yeah. Well, to continue the discussion of where the field is going, if we look at the further development of Asundexian, I understand that the phase 3 trial in stroke prevention is continuing, or at least the plan is continuing, and that would be trying to prevent non-thromboembolic stroke, largely ischemic stroke. And what's your feeling, Jonathan? We have a drug that appears to be, at least at the dose of 50 milligram, largely ineffective in the prevention of thromboembolic stroke. And do you see it as a good idea to pursue stroke prevention of other origin?
Yeah, so let me say so first of all, let me say that the stroke study is ongoing. As everyone knows, it is being monitored by a data and safety monitoring board, and there's been no indication that the study should be terminated prematurely. So the study is ongoing, and it would be inappropriate for me to comment on what one might expect from the results of that. Maybe a different question that I think is reasonable to ask is, in atrial fibrillation, where might Asundexian have a role? Let's just assume for now that that maybe a higher dose might, have greater efficacy. So one of the interesting results that did come out from the subgroup analyses is that there was clearly a difference in the patients who were naive to oral anticoagulation. The magnitude of the increased hazard was much lower. It was still significantly increased, don't get me wrong. And so, one possibility for these patients, maybe if a patient cannot take an oral anticoagulant and they're deemed too frail to undergo an appendage closure procedure, or they're not a candidate for some reason or the other, the group of patients who have no medical therapy options, so to speak, may benefit from factor 11 inhibition. So in addition to waiting for the results with abelacimab and waiting for the results with milvexian, and learning what we can about those, there still may be a role for Asundexian in the treatment of patients with atrial fibrillation, independent of the results of Oceanic AF.
But although I respect your desire not to comment on oceanic stroke, let's ask ourselves, what is the evidence that factor 11A may play an important role in non-thromboembolic stroke as compared to thromboembolic stroke, where we saw substantial lack of efficacy? Hugo, do you see a rationale for such expectation?
This stage, there is no good basis to expect efficacy, but I hope I'm wrong. Maybe the study will turn out better than I would expect. But as I said,
do we have mechanistic information on the contribution of factor 11A to atherothrombotic stroke versus thromboembolic stroke?
Not yet, but we have very limited evidence. We just finished a sub-analysis, one of the stroke trials in the Netherlands in the Contrast Consortium that you also mentioned. We measured factor 11A complexes, but they're at baseline, but there was no relationship with either stroke severity or functional outcome at 3 months. That doesn't mean anything. I mean, it's a limited sample and it's only one biomarker. But we don't have a signal of indication or an indication that there will be an association between factor 11 activation and, what's happening during stroke or its outcome. So I'm a bit pessimistic there, but hopefully I'm wrong again.
And on the other hand, the program in myocardial infarction is on hold. Is that correct? The Asundexian further development plan.
The Asundexian study on myocardial infarction was concept only. It was never launched. A strategic decision was made after the conclusion of the phase 2 studies to pursue atrial fibrillation and stroke.
Okay. There is a comment from John Cleland: if half of the bleeds occur in the 10% on aspirin, problem solved. That's a recommendation.
I would say, Dr. Cleland, I applaud your enthusiasm. As I tell my fellows in clinic, probably one of the most important interventions we can make in AFib clinic is to stop aspirin in our patients. So I hear you loud and clear and applaud you.
So I'm very happy to say that JAMA have just taken a viewpoint on stopping aspirin for chronic coronary disease as well. So we'll see.
Okay.
Carlo, as we are going towards the end of this fascinating dialogue, and as we have a big responsibility because we have 200 colleagues listening to us, it's a very global audience, and this post will be viewed by about 2,000 colleagues. So we have a big responsibility today to give strong and clear messages. So I have a questions for you, a very sharp, simple question. What is your priority in the field of factor 11 inhibition? The first priority in the future with factor 11 inhibition. Jonathan, first you.
For me personally, and I'm answering this question with all sincerity, is for me the most important thing is I want to see the results of the abelacimab phase 3 trial in atrial fibrillation and the results of the large-scale milvexian phase 3 trial. I am not ready to make a final conclusion about the role of factor 11A and inhibition in the treatment of patients with atrial fibrillation yet. We just have one clinical trial. That's all we have.
Thank you, Jonathan. Hugo, next priority with factor 11 inhibition.
So to give a simple answer, I hope we will be able from these studies to, using biomarkers, to get better idea of the mechanisms that are operational. And certainly if there will be differences between the study outcomes, to be able to compare the different compounds and how they act in vivo. I think that will really be necessary in order to understand how these feedback mechanisms, how relevant they are in the different patients.
Thank you. Bianca.
Yes, I agree with Hugo. I'm a bit skeptical about atherothrombosis because if we look at data of patients with factor 11 deficiency, actually the cardiovascular events, the upper limit of the hazard ratio was nearly 1 in the original descriptions. So I think that the Venus, in a way, district would benefit high bleeding risk patients. We don't know. We have to wait for at least in atrial fibrillation. For sure, there are patients with catheter, which need the catheter thrombus protection, extracorporeal circulation, hemodialysis. I mean, those situations maybe are a little bit more clear in terms of pathophysiology to use these kind of compounds.
Thank you. John Cleland, what is your priority in this field? After stopping aspirin 12 patients, what is your next priority?
I guess it's to make sure that patients have access to the best medicines and that they know why they're taking them and they take them. And then after that, we have to think about all the other things surrounding atrial fibrillation, that it's a big driver of heart failure. Should we be ablating a large number of these patients, and so on? For me, the residual stroke risk. If you can find high risk groups where there is a substantial residual stroke risk, it may be worth developing something there. But for the commoner garden patient, you're going to get into an 11,000 patient randomized study. I think it's game over.
Well, it is interesting with top scientists in this field, priorities are so different. Professor Patrono, your priority in this field?
Well, I'm very pleased as a pharmacologist to see that there are at least 10 different molecules or antibodies targeting this particular pathway of coagulation. So in the end, we will know much more than we know today from the consistency or inconsistencies of the findings of different clinical trials. Having said that, I think a crucial aspect, a crucial lesson that we should learn from the experience of Oceanic AF is that we should not overinterpret phase 2 findings, because phase 2 studies are not designed to assess either efficacy or safety. And the overinterpreting their results may be misleading. Phase 2 studies should aim to select the proper dose to move then to phase 3. And perhaps we should spend more time in phase 2 for the right dose selection than is currently spent but essentially the policy, the willingness, the investment of industry. I don't know to what extent do you think, Jonathan, academic investigators can modify the influence of industry in terms of deciding the study design, the size, the duration, and the number of phase 2 studies of a new investigational compound?
Well, I think that we've offered our audience a really very wide perspective. But before closing, my last question for Jonathan. Jonathan, in these dialogues, not only we want to share the knowledge of top scientists in cardiology, but we also try to reveal the human side of the story. So for you, I have two questions. One is your name. It sounds Italian. What about your origin or the origin of your family? Second question is, you are really an expert clinical electrophysiologist with a massive CV on ablation, arrhythmias, and interventions. What attracted your interest towards drugs and factor 11 inhibitors in particular?
Yeah, so let me tackle the first question. I am very proud to have Italian heritage and ancestry. I'm 50% Italian. My family from Italy is from outside of Rome. And the other major source of my heritage is German. The German side of my family is from Baden-Baden, which unfortunately I've never visited, but I hope to someday. As an electrophysiologist in training, I remember listening to a basic scientist talk in his lab, and he was trying to make the point to his graduate students that they shouldn't become specialists on a single method, because if they needed X-ray crystallography to answer a question, they should go find someone to help them with that. Or if they needed to do a unique mouse experiment, well, they needed to get someone to do that they shouldn't be focused on a specific method. And I've taken that approach to clinical research. And so I tell my fellows that, it's fine to be passionate about devices. It's fine to be passionate about medications, but what we should really be passionate about is the problems that face our patients. And that's why I think device therapy, drug therapy, epidemiology, all of these clinical research targets are critically important to answer the questions that afflict our patients and to help them have an improved quality of life. And I really enjoy engaging with all these different therapeutic areas, and to any fellows or young investigators on the call, I think it's important to focus, but it's also important to not to just focus on one thing, but the several problems that our patients need to face every day.
Well, thank you, Jonathan, for these very wise words, which can be of inspiration for our younger colleagues. And I'm speaking from the center of Rome, Isola Tiberina, which is really the heart of Rome. So next time we'll come to Rome, and Carlo is next door. If we go to the window, we can see each other from his house and from my office. So if you come to Rome, please come to the heart of Rome, and you will enjoy our hospitality. Thank you. Now, then I'll give the word to Carlo to close the dialogue. I remind you that our next dialogue will be, as usual, on the last Thursday of the month, so will be on November 28th. And the topic will be more or less how to remain young. You will be challenging, but science is progressing to rejuvenating our body. Will be interesting. And Carlo, closing remarks to you.
Well, just to thank our wonderful team of experts, Jonathan, Piccini, Bianca Rocca, and Hugo and Cate for very interesting discussion, very illuminating insights into what we have seen so far, and there is much more to be seen in the future. And thank you all for participating, particularly those who have sent questions or have made comments like John Cleland. Thank you, John.
Thank you.
Good night.
Good night.